Thank you very much indeed. It's a great pleasure to be here. And having listened to the introductions going around the room, I'm acutely aware of the fact that there's an enormous breadth of expertise here. And so a lot of what I'm going to say will already be very well known to most of you. But I was keen just to make sure that we didn't leave anybody behind with some assumptions of knowledge about particular aspects of Alport syndrome. So my intention with this first very introductory talk is just to make sure that we all get to the same starting point before the experts in various different disciplines teach us a whole lot more. And it's always interesting to start by quickly reviewing the history of the definition of a particular condition because it's slightly accidental that it happens to be called Alport syndrome. There were several clinicians, including Guthrie, as in Guthrie Cards, be familiar to many clinicians, and Arthur Hurst, who'd anglicised his name from Hertz, who described families with what we now know to be classic Alport syndrome. But at least one of them, Dr. Hurst, made the, perhaps with the benefit of hindsight, mistake of publishing his excellent findings in a little red journal called the Guy's Hospital Reports, which is not where you publish if you want fame and fortune. Cecil Alport, in 1927, followed up 3 generations of an already quite well extensively reported family, but made some very pertinent observations. First of all, the fact that some of these patients had hearing problems was part of the syndrome and not just a coincidence. Secondly, he noted that the condition tends to be more serious in males. And he noted that the affected males tended to die of uremia or kidney failure, whilst the females generally lived until old age. And what happened over the next 30 or 40 years is that huge numbers of patients with quite a wide range of inherited nephritides were published under the label of Alport syndrome, but in fact, with the benefit of hindsight, many of them had other conditions. This is the eminent gentleman himself. And I imagine he must have been quite a character. We've been reminded that he was a graduate of Edinburgh University, although he was in fact South African. And in fact, after graduating, he went back to South Africa to inherit the family gold mine. Unfortunately for him, but fortunately for us, it turned out not to have very much gold left in it. So he returned to London to work at St Mary's Paddington in the nephrology unit, where he came across the famous family. But then, being mentored by Alexander Fleming, as in the discovery of penicillin, he went to Egypt to expand his knowledge in infectious diseases, but was so appalled by the poor standards of clinical care there and the levels of corruption in the health ministry that he wrote a book called 1 Hour of Justice, the Black Book of Egyptian Hospitals, which led fairly rapidly to his exit from Egypt, and he returned to London, but feeling very let down by his colleagues who hadn't stood by his side, resigned from the Royal College of Physicians. Now, when I first became interested in Alports in the mid-1980s, we wanted to try, along with a number of colleagues in this room who were undertaking the same exercise, to map the gene for X-linked Alport syndrome. That's always easier, it was in those days, than trying to map the genes for autosomal forms of Alport syndrome. But reviewing the literature, it was very apparent that families with all sorts of different conditions had been labelled as having Alport simply because the condition that they had was genetic. And so we devised a set of clinical diagnostic criteria, which I think have to some extent withstood time. And that enabled us to identify families that we could be pretty sure had the same condition as Alport's original family. And so in our linkage studies, we only used families that met 3 out of the 4 of the criteria listed here. So positive family history, the typical changes on renal biopsy, the characteristic ophthalmic signs, which we'll learn more about later, and high-tone sensory neural deafness. You'll see more renal pathology, I'm sure, in later presentations, but just to show you very briefly what a normal glomerular basement membrane looks like on the left, and then how it can become thickened and split in patients who have Alport syndrome when you review it under the electron microscope. I know there will be some lovely posters and other presentations of the characteristic eye signs, and we're learning far more about how the eyes can be affected in patients with Alport syndrome. Back in the 1980s, there were 2 things we looked for, these little white flecks that one sees around the macula, and also a change in the shape of the lens, which becomes progressively more cone-shaped, and that is associated with the development of progressive myopia. There are some fantastic new bits of equipment nowadays that my ophthalmological colleagues are using that enable them to have a much closer look at what's happening in the retina of patients with Alport's. And one of the lessons I've been learning over the last few years is the importance of suggesting to these patients that they do go and see an ophthalmologist, because I think the eye problems tend to get slightly overlooked. And I now explicitly ask patients whether they have problems with dry, uncomfortable eyes, and it's surprisingly how often they do, but they've never mentioned it to anybody, or if they have, people have moved on because they've been focusing more on the renal function. And yet patients I've known who've gone to the ophthalmology department and seen somebody with a particular interest in Alport's are finding that extremely helpful. Sometimes they've had years of not very satisfactory glasses prescribed for them, and in fact when the lens is removed and replaced with an artificial lens, suddenly their vision is so much better. And practical tips as to how to deal with the dry eyes and so on can prevent corneal scarring. Now, you'll be aware also that patients with Alport's syndrome who start off with normal hearing at birth and whose speech therefore develops entirely normally gradually develop a high-tone sensorineural hearing loss. And this chart here shows you why this is such important. The area marked with a pink boomerang is the area of hearing which is particularly important for normal speech. And so typically these patients find it quite difficult to hear on the telephone because they lose the consonants. Whereas when discussing something with an Alport's patient face-to-face, of course, they can partially lip read, and that does help with their hearing. 80% of the boys with X-linked Alport's develop some hearing impairment at some time in their lives, often by the time they're teenagers, and of course at an age when they are least keen to start wearing hearing aids. But I was very interested to hear from an ENT expert when we had a patient support meeting in Edinburgh last September about the importance of people not only being prescribed hearing aids but also encouraged to wear them every day. And what she told us is that it takes about 3 months for the brain to learn to fully interpret the amplified sound that it is receiving through the hearing aid. And so the practice some boys develop of just popping the hearing aids occasionally when their parents nag them because they don't find them very much use. Actually, they're probably telling us the truth because they're not wearing them regularly. They're not benefiting very much from them. So this is the relevant bit of the inner ear, the cochlea, which is affected in Alport's syndrome. More specifically, it's these very sensitive little hair cells that are lined up there. And if this works, this shows you what happens when a hair cell hears a sound.
1, 2, 3 o'clock, 4 o'clock, rock. 5, 6, 7 o'clock, 8 o'clock, rock. 9, 10, 11 o'clock, 12 o'clock, rock. We're gonna rock around the clock tonight. Put your glad rags on, join me home. We'll have some fun when the clock strikes 1. We're gonna rock around the clock tonight. We're gonna rock, rock, rock till broad daylight. We're gonna rock around the clock tonight.
So that's one individual hair cell responding to a sound. And I'd like to thank Briege McArdle for drawing my attention to that little clip. It's available on YouTube if any of the rest of you want to use it in your talks. I think it's absolutely brilliant. So let's move on now to thinking about the genetics of Alport's syndrome, obviously my particular interest as a geneticist. If you look at the literature, fairly standardized figure from around the world, the disease affects somewhere between 1 in 5 and 1 in 10,000 individuals. As genetic conditions go, that's actually not that rare. But it does mean for individual general practitioners, general physicians, they won't know really many patients with Alport's syndrome unless they happen to have a family living in their area. And it's been pretty well established for quite some time now that 85% of families, so the majority, the disease is caused as the result of mutations in the gene for X-linked Alport's syndrome. That's the gene that codes for the alpha-5 chain of type 4 collagen. And 15% result from mutations in the autosomal genes, the COL4A3 and COL4A4. And of course, we all see families where people present with absolutely no family history of renal disease. And in some cases, that's because the condition in the person we're seeing, and this is usually an X-linked Alport's, has arisen as the result of a new mutation. So the type 4 collagen genes are interesting, big, challenging, difficult genes. They exist in pairs. So the genes for the alpha 1 and alpha 2 chains of type 4 collagen on chromosome 13, and then the genes for the alpha 3, alpha 4 and alpha 5 chains, which are the ones we're most interested in here, the autosomal ones on chromosome 2 and the gene for X-linked Alport syndrome, obviously on the X chromosome. And when I was initially doing my research into Alports, the huge step forward came when Carl Tryggvason and his colleagues cloned the gene for alpha 5 type 4 collagen, which meant that we could move from doing linkage studies to try and help identify relatives and families who might also be carriers or affected, to actually starting to do mutation detection studies and understanding the precise alteration in a patient's DNA that had led to them having Alports. So just looking at the 3, 4, 5 and 6 chains of type 4 collagen, just a helpful summary there to remind us why mutation detection has proved so difficult. These really are huge genes, anything between 46 and 52 exons, and with other disorders as well that are caused by different collagen genes. We know from bitter experience that sometimes trying to find the relevant mutations and distinguish those that are pathogenic from those that aren't can be really quite tricky. But these genes code for chains which then bind up together into trimer molecules, so that's 3 at a time. And there's various different combinations that we can see. Two alpha 1 and alpha 2 chains in this trimer here, a 3, 4, 5 here, 2 5s and a 6 here. There's a number of variations on a theme, and of course when it gets very interesting is when you start to see mutations in the gene coding for one of these chains. So if your alpha 3, alpha 4 and alpha 5 genes are all functioning normally, you can make a trimer like this that has a normal copy of each of the gene. But if we look at the phenotypes down the side here and the molecular defects here, if you have a male who has a mutation in COL4A5, he will present with typical Alport syndrome, and we see a lack of the alpha 5 chain in the triple helix structure there. If it's a woman who's a carrier of X-linked Alports, she will have variable amounts of that gene there, because to some extent the second normal copy of that gene can compensate. When we get down to the autosomal recessive forms of Alports, it'll be either the alpha 3 or the alpha 4 chains that are missing if patients have 2 mutations in one of those relevant genes. If they're carriers of recessive Alports and they are only missing 1 copy of the gene or only have a mutation in 1 copy of the gene, they're likely to be more mildly affected, have hematuria and thin basement membrane disease. But I moved down into this very controversial area where we had a fairly lively discussion this morning, and the great debate as to whether patients who are carriers of autosomal recessive Alports, who have thin basement membranes, but who develop some degree of hypertension and renal impairment, whether we should always automatically refer to them as having autosomal dominant Alports, or whether we regard this as perhaps a predisposition that makes some degree of renal problem more likely, but perhaps only becoming significant if there are also other pathologies present, which we have to admit we don't yet really understand. Now, this is slightly small print genetics here, but it is very interesting. I explained to you how the 2 genes on the X chromosome go head to head here, and it was our French colleagues in Paris who initially reported patients who had a mutation that takes out a variable amount of COL4A5 and the first 2 exons of COL4A6, and they tend to develop not only Alport syndrome, but also leiomyomatosis, which are benign tumours of smooth muscle which can affect the esophagus, the genitalia, and various other regions. The initial very good paper here from Laurent Zaidet in 1997 has in fact recently been updated by a very interesting paper I came across published last October or November, showing a patient who appeared to have a deletion that fulfilled these criteria, but actually does not have leiomyomatosis. So clearly it's not quite as simplistic as we used to think. Autosomal Alports is something that we've been talking about more recently. It's less common than the X-linked form, and the genes for the autosomal forms of Alports were cloned more recently, and so our attempts to screen them for mutations have been less numerous. And we are able to confirm that certainly of the remaining 15% of cases, in at least 10%, we eventually find 2 mutations in either the COL4A3 or COL4A4 genes. To my great satisfaction, a few patients in whom we'd initially only found 1 mutation in these genes, now that next-generation sequencing is being increasingly used, we are tending to find a second mutation in them on the other copy of that gene. And so I remain in the sceptical camp with regard to the existence of autosomal dominant Alports, but I'm sure that's going to be a recurring theme throughout this meeting. And we've learned recently that being a carrier of autosomal recessive Alports is not as benign as we used to think. And in fact, we now proactively follow up all carriers of recessive Alports and recommend that at least once a year they have their blood pressure measured, their urine tested for protein, and then follow the protocol that Oliver Gross and others have published with the early use of ACE inhibition in order to try and reduce their chance of developing significant renal impairment or proteinuria. So it's always quite interesting to go back and review something that you did 20 or 25 years ago and see if it's any use anymore. And so we went back and had a look at the diagnostic criteria that we'd published in 1988 to see how useful they were in determining a subgroup of patients who actually really did have Alport syndrome. And we looked at the number of diagnostic criteria that they met just simply from the clinical information sent to us by clinicians who very kindly send us samples of DNA. And as you can see, the more boxes they tick, the more likely it is that they will have a mutation in the X-linked gene. And this study was just looking for patients with X-linked Alports. There were only a small number who met 4 diagnostic criteria and didn't have a mutation in the X-linked gene, but subsequently we've been able to show that most of those in fact have recessive Alports. So I think that bit of the puzzle is falling into place. And so if you ask us as geneticists what we recommend in terms of genetic testing, certainly if patients clinically fulfill 3 of the diagnostic criteria, it's well worth screening them for mutations in the type 4 collagen genes. In fact, if they only fulfill 2 of them, there's a reasonable chance of finding a mutation, so people may prefer to use a lower threshold. I still generally go for COL4A5 analysis first, unless there's a female presenting at young age or the parents are consanguineous. But this distinction is very quickly going to be surpassed by the introduction of next-generation sequencing, where all 3 genes will be screened simultaneously. The reason at this stage for consecutive screening has in part just been one of cost. We spent a lot of time this morning with some wonderful enthusiasts considering the value of databases where variants are recorded together with phenotype information. So I won't go over that in any more detail. I've already explained why I think it's so important that carriers of recessive Alport syndrome have long-term follow-up. And so when I was thinking where we've come over the last 20 years, I suppose the main thing that's changed is that we now tend to turn to genetic testing as a much earlier investigation. And certainly for virtually all the children that are seen in the Evelina Hospital, Evelina Children's Hospital at Guy's, they no longer have a renal biopsy. We go straight to genetic testing because there is a very good chance that we will be able to give them an answer. It saves them an invasive procedure, which is associated with some risks. And as reporting times come down, it's not taking that much longer to give them an answer either. And of course, it has the benefits of once you identify the specific mutation in a family, you can test other members of the family to see if they are carriers or to provide pre-symptomatic diagnosis. And some of our families are electing to consider either prenatal diagnosis or pre-implantation genetic diagnosis. And I'm very involved in our pre-implantation genetic diagnosis team at Guy's. And increasingly, I think as we do more treatment trials, people are going to want to know which particular mutations patients have, because it may well be that knowledge of the genotype will influence the sort of therapies that patients are offered. My thought for the day, I think this is what I feel I've learned most recently, and the lesson I've learned is not to stop looking for explanations just because you think you have an answer.